Dr. John Bennett of InternetMedicine.com. Today we have an episode of Radiologist.tv with Aizaz Rai, a cardiac imaging contributor, a clinical research fellow in echocardiography at Oxford University. I'm kind of fumbling here. And we have the head of Radiologist TV, Faik Sheikh, MD. So first I'll introduce Faik, and then I'll turn it over to Dr. Rai. Hello, Faik.
Hi, John. Happy to be here. I am very happy to start the second show at Radiologist.tv. I have introduced myself in the previous shows, but I'll just quickly go here. I am a molecular imaging physician by training. I'm the co-CEO of Radiologist.tv and CEO of Crunch Timer. Here we have Dr. Rai, an Oxford alum and clinical research fellow in echocardiography. We are very happy to have you here, Dr. Rai.
Thank you so much.
Well, Dr. Rai, could you tell us a little bit about yourself and where you're training, etc.?
Well, I'm a graduate of King Edward Medical College, which is one of the best medical schools in Pakistan, and then afterwards I have done MRCP, which is Membership Royal College of Physicians of United Kingdom, and afterwards I was fortunate to get a scholarship of Masters by Research at Oxford University, where I did advanced imaging techniques like speckle tracking echocardiography, which I'm going to discuss today, and feature tracking CMR, and my focus was on right atrium mainly, and we have a very nice paper published just 2 days ago. I have mentioned to Dr. Faik about that. Please do go through that if you get time, and this is pretty much it. So shall we begin?
Okay, yeah. Could you tell us a little bit about what you're going to present before you start the show?
Sure.
Okay, just start then. Whatever.
Okay. So let's begin.
Okay.
So I have already done my introduction. So here is, today I'm going to discuss about speckle tracking echocardiography, its basics and its clinical applications. So it seems a bit fancy name. Echocardiography is very much we are familiar with, but speckle tracking, what does it entail and what does it involve? I will be going through the basics of it briefly first. So speckle tracking is a post-processing technique. What do we mean by post-processing? So it means that we use already acquired echocardiography or ultrasound images. It's not pre-processing technique or processing or during imaging processing technique, but it is a post-processing algorithm, a mathematical algorithm which we apply post hoc or during post-processing while we are processing the data of echocardiography, and it is used to track movement of speckles or blobs. So speckles or blobs, I would spend some time on this because this is important to understand the whole concept of speckle tracking echocardiography. These are the grainy textures, small grains. Sorry about this. These small grains which you can see in this slide. Here we can see the small grains, dark and bright. These small blobs or speckles or grains, these are called speckles, and these are formed by constructive and destructive interference of ultrasound waves. What do we mean by constructive and destructive interference? Constructive interference is basically when crest of one wave falls over the crest of another wave and they are in phase. When one wave supports other wave and the resultant signal is positive or hyper intense or bright. And destructive interference is when one small wavelength ultrasound waves falls over the other wave while they are not in phase. So they decohere and they cancel out each other. And we have got dark signal in that case, and that appears as hypo-intense or non-intense. So the second important point to understand is that speckles form the fingerprint of the heart, which means they represent the underlying tissue architecture. If the underlying heart is diseased or abnormal or pathological, then we will be getting a different pattern of images than what we get from the normal heart. So these 2 points, are we clear on these, or do we have any questions up till now?
Sure, we can go ahead.
Okay, sure. So speckles are basically formed by constructive and destructive interference. We have discussed that. So now we select specific areas of the myocardium, and these areas of myocardium are labeled by a computer science function which is called kernel, which is basically input-output function. I won't go into the much details of that, but we label this very small, minuscule portion of the myocardium by these kernels, and then we track these kernels from frame to frame throughout the cardiac cycle. So just giving one example, we have region of interest in image at t0, time 0, and we search. The algorithm moves forward as the heart contracts, and dilates, and search the area in image at t1, at time t1. So we find the best match at a specific point, and this block basically shows that kernel which has a specific number of kernels, usually 30 to 40 in most algorithms that are commercially available. So basically we track these, and we basically detect the distance covered and the time taken. So distance, as we know from our elementary school mathematics, that distance over time is velocity in a specific direction, and distance covered, when we minus it, we get displacement, and we see in a minute. This is again the blobs or speckles which are traced through in a kernel from one position to time position and one spatial position to another. So this is kind of, we have the mathematical relationship. Displacement can be used to derive tissue velocity, and displacement also can be used to derive strain, which I will be explaining in a minute. And strain can be used to derive strain rate. So these are the 2 parameters which we measure during speckle tracking echocardiography: strain and strain rate. So we have to measure the displacement and velocity, and then we convert them into strain and strain rate. What is strain? Strain is basically change in length relative to original length. So final length minus original length divided by original length, that is strain. That is basically deformation or change in shape of the heart. So we are measuring basically the change in shape of the heart, and we measure it in mathematical terms in various measures, which I will be explaining in a minute. And when we bring in the temporal component of that strain, it is strain rate, which measures the temporal component of the strain and the mechanical changes that occur over time. So do we have anything else before we started using speckle tracking derived strain in 2003-04 roughly? Yes, we had Doppler derived strain, which was there since 1980s and 1990s. So basically what we did was, what we do in Doppler derived strain, we basically measure the distance and velocities which a wave travels after striking heart walls, and applying Doppler principle, we measure the strain through certain algorithms. But there are 2 or 3 inherent problems with Doppler derived strain. Number one being the angle dependence. We know that when we apply pulse or a wave in a specific direction, it would come out at a specific angle depending upon the angle of insolation or angle at which we sent it. So
Dr.
beyond
Wright, excuse me, Dr. Wright, you're still on the first slide, the basics. Is that where you want to be?
no, this is not first slide. I think it's
You're on the first slide now. I don't know if you want to be there or not.
I think there is some issue with the system.
It's adjusted, so go to the slide you want to show.
Okay. I think I will start the slideshow again.
Okay. Limitation of Doppler-derived strain, is that what you want?
Is it okay now?
It's limitation of Doppler-derived strain. Is that the slide you want, Dr. Wright?
Is it okay now?
Yes, it's limitation of Doppler-derived strain. That's the slide it's showing.
Are you seeing, which slide are you seeing now? Hello?
Yes. Which slide do you want on there? It says why we need speckled tracking right now. That's the slide.
I think the slides are moving in real time. We're just having some lag with the voice.
Sorry, I'm not being
But
able
the slides
to
are
hear you.
showing in real time.
Okay.
Hello?
Yes. The slide that's on now is why we need speckled tracking.
Hello?
You can't hear? Can you hear me? Can you hear me, Dr. Rye? Can you hear me? Hello, Dr. Rye, can you hear me? Can you hear me, Fike?
I can hear you, yes.
Dr. Rye, can you hear me? I think you lost the audio.
Hello?
Yes, can you hear me, Dr. Rye?
Now I can hear you. I think there was some line issue in between.
Okay, and bandwidth, okay. Okay, you have a
Okay,
slide,
sorry about that.
why we need speckled tracking. Is that what you want?
Sure.
That slide. Whoop. Bandwidth.
Simon is here.
Hello,
Yeah.
Fike. Hi, nice to see you.
How are you doing?
Long time no see. Very good, thank you.
Yeah.
4 o'clock in the morning, 3 o'clock in the morning over there.
Some
Okay,
crazy
Dr.
hour.
Wright, Dr. Wright, you're back on. That's carry on.
Sorry
hear
about
us?
the glitches.
That's okay, no problem. Let's continue.
Okay, so one important point which I slightly skipped was why we need speckle tracking when we have so much other very good measures like ejection fraction, volume, and mass are available. The one problem with them is that ejection fraction, volume, and to some extent mass are load dependent. Means if there is increased preload, means if there is increased blood being pumped into the heart, the volume and hence ejection fraction would increase. And if heart has to pump against increased resistance, that is increased after load, similarly the ejection fraction would get affected and volume would decrease. And second, ejection fraction, volume, and mass give us global function. Yes, if we have to pinpoint a specific section of the heart, we can, that this section of the left ventricle, this segment is diseased, we can do so in a rough manner, but exact pinpointing the exact pathology is very much difficult. Eyeballing is very much standard in most parts of the world, but on eyeballing we can just give a rough estimation that anterior wall, but which section, upper mid or basal or whatever. So we need some measures which are which give us regional and global function as well, and which are load independent. And strain spectral tracking derived strain is one such measure. So now back to where I was. Doppler-derived strain is one of the parameters and one of the techniques that we used before spectral tracking. But it is dependent upon angle of insolation. Means if we increase the angle of insolation by more than 30 degrees, the strain values would change significantly. There would be significant changes in the strain measured by from 0 degree to 30 degree change in angle dependence. And the frame rate requirements, they are quite high, close to 100 to 150 frames per second, which are sometimes not possible in all patients, in all machines. And it has poor lateral resolution, which is again the angle dependence, and it has complex post-processing. So it is a robust technique. Doppler-derived strain is a robust technique. It is very well validated, but it is angle dependent and needs high frame rate. So the types of strain that we measure through, like we have 3 dimensions. So we measure strain in 3 dimensions: longitudinal, circumferential, and radial. So 3-dimensional strain, or we measure on 2 dimensions, we measure 3-dimensional strain, or we measure it in 3D as well. And now 4D in latest papers that are coming out from the latest research, in which real time, we are measuring the strain in real time. So types of strain are radial, which is very well obvious from the figure, and circumferential, it measures the strain in the circumferential direction, and longitudinal, which is lengthening and shortening of the strain of the heart, which leads to strain which is in negative direction, because longitudinal strain, heart shortens, so the strain decreases. Circumferential, radial is positive, and circumferential is again negative in normal people. We will see in a minute. But here is an interesting concept that I would like to introduce. I'm sure most of you would be knowing it, but still I would like to, that heart has apex, and on the left side of the figure, and over here, and base. These rotate in opposite directions. So when a chamber or a cylinder, as we may call it, when they rotate in opposite direction, it is like a ringing movement, or just like we rinse the cloths. So it is called the twist. As the name is self-explanatory, it is twisting of the heart. And according to some very high reliable sources, it is responsible for up to 70 to 75% of ejection fraction of the heart. But we are not conventionally taught this twist and torsion in medical schools. Mostly, I don't remember we were taught when we were in undergraduate years, but it is very interesting concept, and we will be measuring it we will be seeing its application in some of the patients in a minute. So here is another figure which shows the apex and base rotating in the opposite direction, which leads to twist of the heart. And this is an application of apical rotation. I will just skip this one. And now comes the question that we have a technique. It's good. It looks fancy. It has applications that we'll see in a minute. But can it be validated against the previous gold standard techniques? So the answer is it has been validated against sonicometry and CMR. So this slide is showing the validation against sonicometry. Sonicometry is the technique which was there before we had imaging techniques like MRI and echocardiography in routine use in heart. So in 1970s and 1980s, we used to put small metallic implants on the heart and then take images of the heart during cardiac surgery or in animal studies. So this was the gold standard in the past, and spectral tracking echocardiography has been validated against sonicometry. Now next question comes that we have a technique which is good, it is validated, but for saying something to be abnormal, we must have some normal values. So we basically introduced the concept of normal ranges And there have been so many studies which have been done on the defining the normal reference ranges of various components of spectral tracking derived strain. And this is one of the studies which was published in JACC, Journal of American College of Cardiology, and which is showing the normal reference ranges of all walls and anterior and inferior.
Excuse me, Dr. Rai.
Sure.
I'm sorry to bother you again,
Yep.
but I think we're stuck again on the slide. Sorry to bother you.
Oh, which
We're
slide?
we're on the slide why we need spectral tracking. There you go. You're moving now. Yeah.
Let me start it again.
You're on athlete's left LV strain.
Is it okay now?
It's athlete's LV strain. Right now, you're on that slide.
Twist, apical rotation, validation against sonicometry. Are you with me?
Yeah, you're on athlete's LV strain right now.
Okay.
Okay.
Okay. Okay. So now we are coming to the applications of clinical applications of spectral tracking echocardiographies. One of the first we take is athletes. So athletes, they have comparatively different spectral tracking derived strain from normal individuals. And the strain varies with exercise, endurance exercise or aerobic exercise. So with different types of exercise, we have different strains, and we have different strains from the normal individual. This is one example in which we have left atrial strain of athletes in controls, which means healthy population or normal population. Health is not the right word to say, or normal population, and the athletes. So you can see clearly the curves are quite different and from in athletes than in controls or normal population. So we can differentiate between the cardiac function of athletes from normal population, and we can see how much endurance training has strengthened their heart. And second thing, which is most important, is that we can differentiate physiological hypertrophy, that is in athletes, from pathological hypertrophy, which is in hypertrophic cardiomyopathy, or aortic stenosis for that matter. So here is one example of hypertrophic cardiomyopathy strain, which we can see that in circumferential strain, which is along the circumference, as I have shown you a slide sometime back, and longitudinal strain. This is the strain, the red is the strain in the hypertrophic cardiomyopathy individuals, and blue is the strain in normal population. So circumferential strain and longitudinal strain is decreased in hypertrophic cardiomyopathy individuals. Another very important application which I really like is that genome and phenome in association. Like physical characteristics of the heart can be related to genes in the genes which regulate the heart. And here we can see that in the upper panel, genotype positive reverse curve. This is the reverse curve type. Reverse curve. Genotype positive and genotype negative sigmoidal have clearly different curves of strain, of longitudinal strain in this case. This is a four-chamber view. So apical four-chamber view, the heart is shortens, and that's why we have negative strain. So genotype positive and genotype negative have clearly different type of curves. So by looking at the curves, we can clearly differentiate them. And here again, the circumferential strain and the longitudinal strain, they are decreased in. Now here is an application of torsion, which we were discussing, twist and torsion, which we were discussing a while ago, which is due to writhing bringing or rinsing movements of the heart in diabetics versus healthy controls. In diabetics, the rotation of the heart is increased. The rotation of the heart is increased as compared to the healthy controls. So moving on, this is again very important application is post-cardiac surgery strain compared with heart transplants. So you can just by looking at the figures, if we don't know the number even, we can clearly see that the heart strain in normal people versus cardiac surgery and heart transplant is different. It is decreased in post-cardiac surgery and it is markedly decreased in heart transplant. So heart transplant patients cannot retain the same cardiac function as they had before the cardiac transplant. This is very obvious example of that. So they have a transplanted heart, but their function is not as compared to the normal heart. And this is again an interesting Takotsubo cardiomyopathy. It is stress-induced cardiomyopathy, mainly in females in Japan, but now like it is prevalent everywhere in the world. So basically, it resembles, it's a diagnostic dilemma to differentiate from anterior wall MI. So
okay,
this,
excuse me, Dr. Rai. I'm sorry, Dr. Rai, I'm sorry to keep interrupting you. You're still on the athlete's LV strain. I think you need to manually check on the slides on the left to change them. Okay.
okay.
I think
Sorry about that.
That may work. Okay. Okay. Now you see what slides you're on, right? Just click on the slides when you want to change them. Okay. I think that might work. That might work.
Okay.
You can see the slide, right? In front of you?
Yep.
Yeah, okay, just click on the slide when you want to change it. I think that'll work best.
Okay. So aortic stenosis.
Yes.
Aortic stenosis is another application where we can detect the derangement of heart function before it clinically manifests. And it is obvious from this slide that the Doppler, TDI's tissue Doppler is not very much decreased, but the strain is very much decreased as compared to the normal functions of the heart of echocardiography or traditional echocardiography. Are you with me now? I'm on subclinical LV dysfunction in aortic stenosis.
Yes, we can
Hello?
see that.
Yes. That's good.
Yes.
Okay, thank you.
Subclinical,
Okay, thank you so much.
Yeah, subclinical LV dysfunction.
Okay, so subclinical dysfunction, that was a paper that was published in JACC, and it discusses basically the subclinical dysfunction in aortic stenosis. So genome-phenome association, should I go through it again, because I think the slide wasn't there. So briefly, I would just describe that genotype positive reverse curve, like the curve of the heart is reversed, and it is genotype positive. It has different strain curves than the genotype negative type. So we can associate genome with phenome or the phenotype. Not all genes, but some of the genes which are responsible for the hypertrophic cardiomyopathy, because hypertrophic cardiomyopathy has got so many genes and it has been an area of extensive research by so many groups in the world. But some of the genes we can associate with the phenotype of the heart on conventional echocardiography and spectroscopic echocardiography. So basically we have decreased circumferential strain and longitudinal strain. And here you can see that the segmental strain is decreased in almost all segments of the heart on circumferential and longitudinal strain. So in diabetes, we have more rotation of the heart as compared to the normal controls. Here we have healthy controls, and here we have diabetes. The angle of rotation here is about 39 degrees, and here it is about 14 degrees, which is almost 3 times the normal population. So in diabetes, we can define the degree of extent of diabetic heart involvement depending upon looking at the rotation and twist and torsion, how much the twist and untwist of the heart is taking place. We can see how much heart is damaged and how aggressive our therapy should be. Now this one is again a very interesting application, which is heart surgery and heart transplant. And from normal controls to post-cardiac surgery to heart transplants, there is a continuum of the disease process. And post-cardiac surgery to heart transplant, the heart function tends to decrease, and heart transplant function, it does not recover to its original level even after complete remission. And Takotsubo cardiomyopathy, it's a very interesting disease which is prevalent in Japanese, originally described in Japanese population, Japanese female who had stress, and it is stress-induced cardiomyopathy, and beta blockers are therapy. Anyway, it is used to differentiate between the anterior wall MI and Takotsubo cardiomyopathy, which is a diagnostic dilemma of we often tend to misdiagnose Takotsubo and as anterior wall MI, but here different segments of the heart, like mid-anterior segment and basal inferior segments, these two segments are different in these two pathologies. And heart failure with preserved ejection fraction and the normal ejection fraction, needless to say, just look at the curves, and the strain here is normal, while here it is markedly decreased, and it is one of the diagnostic thing in diagnosing heart failure with preserved ejection fraction or diastolic heart failure, which we used to call it in the past. And now comes the infarction. Sometimes we still miss infarction and angina on traditional echoes, but just if we do the strain imaging spectral drive echocardiography, we can clearly identify a non-infarct region from the infarct region. The curves are totally in the opposite direction. And one of the advanced concepts is post-systolic shortening and the reperfusion injury. And here you can see between the two panels that normal aortic valve closure, it moves towards the later time point when we have ischemia. But when we have reperfusion, the curves return towards the normal side and it shows recovery. But it is associated with arrhythmia, reperfusion injury and arrhythmias. So we can see if we do the routine and serial echocardiograms and do the strain analysis, we can see when to intervene for reperfusion injury and arrhythmias. And again, dilated cardiomyopathy, clearly we have normal curves in the normal population, while we have all deranged curves and decreased strain in the dilated cardiomyopathy. And similarly, we can differentiate between restrictive and constrictive. And I would quickly move on to emerging applications. I would spend some time on this. We have papers and research, very high quality research emerging on subclinical brain infarcts. One of the example I have given here is Cable study, in which they have shown that those people who had decreased longitudinal strain of left ventricle, they had subclinical brain infarcts on MRI in the brain. Similarly, a very recent study published just a few days ago, in which they have shown that left ventricular longitudinal strain is very much useful in atrial fibrillation prediction. And one of the clinical research fellows in our group in Oxford University, he has done some landmark work on preterm heart and shown that spectral tracking derived strain and CMR drive strain can be useful in predicting the outcomes in preterm hearts, even after 20 to 30 years after their birth. And then it can be used in pulmonary hypertension and left and right atrial mechanics. And right atrium is basically my area of expertise, but I won't go into the details right now because I think I've taken already a lot of time, and some time due to the technical glitches. I'm sorry about that. And any questions, please.
Yes. Yes. Thank you very much, Dr. Rai. And I'm sorry about the glitches, the technical glitches, but it looks like a fascinating subject. And I'll let Simon. It looks like Simon's chomping at the bit to ask a question.
Hi. Hello, Dr. Rai. I'm sorry to arrive late to your presentation. Very interesting to hear that you are in England. I'm English, and I'm actually from Coventry. And overall, so very interesting to hear about the studies in Japan, because I am coming to you from Tokyo, Japan, and I'm a medical student and currently training in the Department of Diagnostic Radiology, so of course I'm very interested in imaging. I have a question, this is very new to me, very interesting, regarding the speckle tracking echocardiography. Who is qualified to read this this data? Would a radiologist, a generally trained radiologist, be able to read this, or would you have to be specially trained?
I think my first response would be the grass is greener where you water it. So anybody who spends time in it is at present it is in cardiologist domain, but it's basically anyone who spends time in the lab, echocardiographic lab, radiologists and cardiologists both, because it has so many applications. It is so interesting, so many applications for the patient's benefit. I would say that it is for both cardiologists and radiologists.
I see. Thank you.
So anyone who spends time, I agree. It's not easy to master it in just few days. It would take 2-3 months, and learning curve must be steep. So
I see.
One has to spend time. But I think, and I must say that it is unfortunate that despite so many studies, about 4,000 or 5,000 or more than that on PubMed, and so much data churned out, so many good trials and everything, still it is not in routine practice. I think both cardiologists and radiologists should be using it.
I'm looking at this. I'm sorry to interrupt. I'm looking at a study now in the Indian Heart Journal, and it's a journal. It's in. I'm reading it through Elsevier. It says, "How do I do it? Speckle tracking echocardiography." Manish Bansai and Ravi Kansalibua. I don't know if you know about this, but it's a very interesting article.
I think on speckle tracking echocardiography from Dr. Seno Gupta has done some very, very landmark work. Parthu Seno Gupta, and last year he had the landmark keynote speaker on American Society of Echocardiography, and Indian Society of Echocardiography, they organized World Echocardiography Conference 2 years back, and they had live reporting from US and some other parts of the world to the distant remote villages where they just took the portable echocardiogram. So it's a very much easy thing. Like portable echocardiography is now not more than $5,000, and we can just have a PC with software. Software is a bit expensive.
I'm wondering if you mentioned there's a Japanese study, female patients in the Japanese study. Is this something that that is quite a famous study that I'd be able to bring up in my department?
Sure. The Japanese study, I think, we had a fellow from Canada, basically, and she had done some good papers, basically on CMR, but I think we did some on speckle tracking echocardiography. It is very much in the literature, and I think.
I see. I'll check it out. Thank you very much.
More than welcome. More than welcome. Thank you.
Mike, do you have questions?
Yeah, I just wanted to talk a little bit about his recent publication, the cardiology.
Should I explain, Feigman? Dr. Feig?
Sorry, yeah, go ahead.
Okay, so basically it was a review article in which we had reviewed the anatomy of the right atrium, physiology, what are the challenges in addressing right atrial speckle tracking, how we can overcome them, and how clinical trials and future applications of right atrial strain, right atrial fibrillation, pulmonary hypertension, right atrial congenital heart disease, and ventricular septal defects, all of them can be addressed in future studies. At present, we have very few of them, but we can address them in future if it goes mainstream. So basically, it was a review article.
Right. Yeah, I did. What I'll do is that just next to the talk website, we're going to have that article posted there as well, so that the audience can and the viewers can access it and learn from it as well. So, yeah, that's a very, very good presentation. Thank you so much, Dr. Rai, for your for the talk. And
really sorry about the technical glitches. I'm really sorry about that.
It's okay. We'll get better.
Yeah, and well, it's part of having an international network where people.
Just one quick question, Dr. Rai. Do you foresee this becoming a bigger tech that will become more popular in use by ultrasonographers, or do you foresee it just kind of fading out?
Well, if you ask my long-term goals, in short term, I want to be a radiologist of international caliber, and in long-term goals, I want to change the world for better.
Mm-hmm. Very good. Very good. Okay, very good. Oh, I'd like to thank you, Doctor, and we look forward to hearing you.
Thank you so much.
Look to hear more from you with your presentations. And thank you, Feig, for getting Dr. Rai. And thanks, Simon, for coming. And we'll see you the next show.
Okay.
Thanks, everyone.